Welcome everybody. It's 4 p.m. Italian time, so it's time for Food for Veins and Veins for Food. As always, we will welcome 30 seconds to allow everybody to be welcome in the platform. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And welcome everybody again to Food for Veins and Veins for Food, a not-for-profit humanitarian and educational initiative that always start with the heart and art of Monica Glowinski, dedicated to all the health professionals around the world who have shown such a good heart in this tough COVID time, to which this also humanitarian project is dedicated, meaning the support to the post-lockdown economic crisis that has been reported recently by the Lancet Journal Call. Nothing would have been possible without a truly stellar faculty of friends and world-renowned experts and the many colleagues and friends who have joined us along the way. And this is the chance to deeply thank also the many attendees of last Sunday webinar. As we deeply thank Professor Mark Meisner and Professor Neil Kiljani for having taken extra time after last Sunday webinar to reply to all the questions we have received during the live in whatever language. I remind you that also today you can make your questions in your language, simply writing them in the question and answer box. The ones that will receive more likes will be answered live. On the other ones, because of course of time limitations, will be answered during the week in a written form and posted in the Viewing Foundation website. Today we focus on the important topic of lasers for spider veins. As always, we deliver international and national CME credits, and as always we enjoy top speakers in the person of Fabricio Santiago and Raul Gindal. We will introduce them properly later on. I take this chance to deeply thank once again Professor Gindal and Professor Santiago, but also Professor Kazumiaki and Professor Goldman for having taken part in extra educational material delivery in the form of recorded video lessons you can find inside the Viewing Foundation educational platform. I take this chance to deeply thank Professor Kikuchi, Professor Mann, Professor Miyaki once again for their role as honorary chairs, meaning that they will wrap up the concepts we all should take home after this webinar, but not before having enjoyed the precious contributions of our continental top experts. We will introduce them one by one later on during the scientific moment of the webinar. Nothing would have been possible, as I was saying, without a truly global effort involving the faculty, individual donors, and also what we call the Magnificent Seven companies who provided unrestricted grants in the person of Amnon, Balton, Bayer, Medi, Servier, Sigvaris, Tactile. I deeply thank all this group, and I truly hope that all this group will be together once again in a food moment at this time dedicated not just to humanitarian and educational support, but also to the pleasure of being together once again. Today we could have been together for celebrating with a birthday cake our friend Marcondes Figueiredo from Brazil, since it's his birthday. And as always, nothing would have been possible without a tremendous teamwork with the ones I consider not just top colleagues and friends, but also family. So the mic now is to Professor Bottini in Argentina. Oscar?
Thank you, Sergio. Dear friends, it's a pleasure to be here again with friends and experts from all around the world, sharing and enjoying another scientific Sunday. Remember, the question and answer box is waiting for your question, which can be made in any language. Les recuerdo que pueden realizar sus preguntas en el box de preguntas y respuestas en español durante la presentación. Bienvenidos una vez más y suerte con sus presentaciones.
Thank you so much, Oscar. Willie from California, 7 a.m. Thank you for the commitment.
Thank you, dear friends, dear colleagues. Good morning, good afternoon, good evening, and let's enjoy the show again. 各位同道们，各位朋友们，大家早安、午安、晚安。今天是我们第11次的网络晚会，请大家如果有任何问题，请在我们的答问箱里问答，我们会极快的给你答复。谢谢。
And thank you so much, Willie, also for the coordination with the Chinese friend. As you know, we always start with a guest of honor who is coming from a ward outside the venous ward, but that in some sort of way is contributing to public health and also venous and lymphatic awareness. This is a top moment for us. It's a huge honor having with us today Giampaolo Montali. Giampaolo Montali is the General Director of the Golf Ryder Cup that will be held in Rome in 2023, one of the largest sport events in the world. He has experiences also in the major leagues of volleyball and soccer. He is a sport world ambassador for Rome. And he also has written a very interesting textbook I really suggest you to read that is really in line with the vision of our friends and colleagues, which is entitled How to Win in the Organization by Teamwork. And here is his message.
Dear all, first of all, I apologize for my English. Being here as a guest of honor in front of you all, world-renowned experts, is actually my true honor. In the same way, it's a real honor for me to represent the Italian golf world and testify the constant attention this amazing sport is dedicating to health promotion. Transversally to whatever nation, age, and gender. And I am pleased through initiatives like the one of today to have learned the calf pump is considered like a peripheral heart because we truly need to make our peripheral and central heart beat together along the 18 holes of Rome's 2023 Ryder Cup. Whereas, once again, the real winners will be sociality, sport, and of course, the promotion of the good health. Sincerely thanking you all for the contribution you are given around the world, particularly in this challenging time, to people's health. I wish you the most productive continuation of this commendable humanitarian and educational initiative. All the best possible.
And with this, we deeply thank you, Giampaolo Montali, for the important contribution in public health promotion through the Ryder Cup 2023. As you know, we always try to keep the atmosphere alike, coupling our venous legends with artistic or sports legend. And of course, in honor of Giampaolo Montali, we have to stay together on the sports legend. And for this reason, it is easy for me to make the comparison of our Fabricio Santiago with the big Michael Jordan. As you can see, is also expressing himself in sport during our past events, looking forward for having him again in the future ones. Fabricio Santiago is the head of the Institute for Venous and Lymphatic Disease. He has interesting publications in PubMed regarding aesthetic phlebology, and we are used to say that it's not just where you are going, but also who you are traveling with. And of course, Raquel Santiago is the best ID that Fabricio could present to us. So Fabricio, we are looking forward for hearing from you about aesthetic laser in phlebology, instructions for users on the available devices.
Hello, good morning. Let me share my screen first. Can you see my screen?
Yes.
Okay, let's start. Good morning, good afternoon, good evening, everybody. Thank you, Sergio, for this kind invitation. My name is Fabricio Santiago. I'm a Brazilian vascular surgeon, and I'm going to talk to you about aesthetic lasers in phlebology and the instructions for users on available devices. I have no disclosures for this presentation other than my personal passion for the vein and lymphatics field. As you can see here, we have what we've been doing so far, cooperating with some national and international centers, and also by performing some very nice investigations. Some of them are going to be published very soon. Let's start from the beginning. This is what we have when we're talking about transcutaneous lasers. This down part, we have the handpiece, and inside this handpiece, we have a small box where we have a laser medium That can be a solid laser, a gas, or can be a dye. And this medium is going to be stimulated by an electrical, an optical, or a thermal source. Usually it's going to be an electrical source, a flash lamp, and it's going to dislocate the electrons from their original orbit. So when the electrons comes back to the orbit, so we'll have the photons. By opening the cavity and with the help of a pair of lenses, voila, we have the laser beam that is going to be always coherent, always monochrome, and always be collimated running into parallel rays. Once the laser reaches the tissue, we'll have some basic phenomena occurring. We'll have absorption, that is our main goal, actually, but we'll have some transmission, we'll have some scattering, and we'll have also some reflection. And the intensity of these interactions, they are going to depend on the wavelength that you're using, on the spot size, on the energy that translated by fluency is the division of energy by the spot size, and the pulse duration or exposure time is going to be chosen by the thermal relaxation time, that is the time taken for the structure to lose half of its temperature. So let's see something about the literature. This is a not yet published review that is being made by a Brazilian group of investigators, where they're comparing different treatment modalities for telangiectasias and reticular veins. Dr. Nakano kindly allowed me to show some preliminary results, and we will see that when we compare these different treatment modalities, we have no differences in terms of efficacy. This is very good, showing that transcutaneous laser works really well for this type of indication. But on the other hand, we know that we're not talking about human material. We're talking about the material that is used for performing sclerotherapy. As an example, it's a lot cheaper than the laser devices. We have some contraindications according to the literature. They're not absolute. Really careful by using lasers in pregnant patients, patients with tanned skin, patients using ferric supplements and photosensibility disorders, patients with hypertrophic scars, when you're treating patients with previous herpes on the area, patients with active skin infection, and in cases of open wound, although we know that we have some wavelengths that can stimulate also the granulation. We have several types of lasers from different laser mediums generating different wavelengths with different indications, advantages and disadvantages. We won't have time for discussing all of this, but we have some guidelines published. This is a guideline published by the European Society for Laser and Dermatology from 2015, showing that we have high recommendation gradings for different types of lesions, of course, with different scientific backgrounds. So this is a figure taken by the book of Professor Goldman, showing the basis of what we call the selective photothermolysis theory. This is a theory showing that for different wavelengths, we have different chromophores and different absorption coefficient peaks correlating to the different wavelengths. Now I want to show you attention for this wavelength. All phlebologists must keep the infrared 1064 nanometer wavelength in mind. This is because not many people know that, but it is not a so good hemoglobin. It doesn't have a not so good hemoglobin absorption coefficient, as we can see here on the figure, but it does not interact. It interacts poorly with the melanin. On the other hand, allowing us to use on high Fitzpatrick skin type patients, and also allowing us to treat larger and deeper vessels once the 1064 penetrates more. So when we look at the literature, again, we can see that with a high recommendation grading and with a high level of evidence, we have the 1064 indicated for treating leg veins, although not indicated with high recommendation grading for some other lesions. But we know that the 1064 nanometers works really well and can be used for treating different vascular lesions. And we are going to show you some slides here from some cases. They are for my private practice. All the patients signed an informed consent for this presentation. And I'm going to show you, for an example, the monotherapy for telangiectasias. I ask you to pay attention for the parameters that we are going to use. This is a situation where we treat, for an example, spider veins with the optimal result. This is obviously, we don't have always this kind of result, but once we have the total disappearance of the spider vein, you need nothing else or perform, for an example, sclerotherapy. This is an example of a situation where the monotherapy worked really well for reticular veins. The above pictures, we have the pre-treatment photos, and below we have post-treatment photos, the immediate result, using different parameters that we have used in the previous situation. Some other indications where the 1064 works really well. This is something that I've been doing a lot with the patients that comes to the office for treating leg veins, treating cherry angiomas. We've been treating venous lakes with very good results in the mouth, sometimes in the oral cavity, facial telangiectasias in the face. And this is a situation that I really ask you to pay a good attention, because especially in the nose, we have a poor tegument, so the chances of having an ulceration here increases. As you can see, we use the small spot size with fluency higher than we were using in the previous slides with the larger vessels. This is another example of facial veins, bulging veins in the temporal area with a very nice result, as you can see in the post-treatment pictures, using the adequate parameters for that. And this is an orbital vein with a very nice result as well. And this is the basis for using the 1064, for an example. When we compare the small vessels with the large vessels, you can see that we usually, for small vessels, we usually use small spot size because we need to bring the laser to the surface, and we have to decrease the pulse duration according to the TRT of the vessel. Usually the TRT are lower than the larger vessels, but we have to increase the energy, and this happens especially because when you bring the laser to the surface, more scattering is going to occur, and you have to compensate by increasing also the energy. On the other hand, for larger vessels, we usually use larger spot sizes because it needs to penetrate more, increasing the pulse duration according to the thermorelaxation time of the structure, but we need to use less energy than when we're comparing with the small vessels. This is the first problem that we're facing when we're using transcutaneous lasers. When we look to the lower limb venous universe, we know that we have several connections of the telangiectasias and the reticular veins with the superficial system, the saphenous veins, or the deep venous system. It doesn't matter if it's reflexive or not. We'll have difficulties on treating some types of patients because of hemodynamics problem. And this is why we usually use association of techniques, the transcutaneous laser with sclerotherapy in these situations. We have some publications. We have Moreno Moraga's technique, a group of Spanish colleagues that have published the use of foam first, and after that, the use of transcutaneous laser. In this situation, the chromophore is going to be the bubbles. And we have a very well-known technique that is the CLACS, that was developed by Dr. Kazuo Miyake. This is a Brazilian technique that has been performed all around the world with very nice results as well. And the other problem is the pain caused especially by the 1064 nanometers. This is an investigation that we have presented in 2011, comparing transcutaneous laser and sclerotherapy in leg-based treatment, using the visual analog scale and analyzing with analysis of variance. And we can see here that we have more pain by using, for an example, the 6 millimeters spot size when comparing with the sclerotherapy. Then for that pain management, we usually need to cool the skin. We have some literature showing that by cooling the skin, we'll have less pain, and we need to cool the skin also for protect the skin from heating. This, the most of the guidelines tell us to do for pain management and also for the skin protection. And this is the other problem. The laser devices they are really expensive. So I really advise you to make some math about that, or if you do not want, you need to consult a financial expert. This is an example of calculation, for an example, the return of your investment, or you can also make some partnerships to minimize the costs with other phlebologists or with some dermatologists for that. Well, it doesn't matter the reason you decided to buy a laser device. This is probably the golden instruction of my presentation. Do not look only for the yellow door. Do not buy these devices only for treating leg veins. You have to explore the best that you can for treating cherry angiomas. It can treat breast veins, facial veins, superficial hemangiomas, spider angiomas, and it can treat also some venous legs with very nice results, as I have showed you before. Some innovations and new perspectives. This is a publication where Sergio Giannazzini was involved by mixing wavelengths for treating small telangiectasias. This is a portable device that has been developed by a South American company for treating telangiectasias. They are showing very nice results with it. And these are some new perspectives, because we know that the 1064 usually comes with the Nd:YAG laser medium. And this is a publication where they have used the diode laser, and this could minimize the costs of the device. We need to know that this is a brand new technology. Only in 1960, Charles Towns gave birth to the laser technology, and Anderson and Parrish have published only in 1981 the selective photothermolysis theory. And this is how we choose nowadays our pulse duration. This is the thermal relaxation time, as I told you. Nowadays, we've been working with the thermal damage time. This is an example of how we choose our parameters in accordance to pulse duration. But this is what we need to keep in mind in the present and in the future is the Arrhenius thermal damage equation. As I told you, we've been discussing more thermal damage time rather than thermal relaxation time. It works with the accumulated tissue damage. It works with the denaturing time and also with the composition frequency that we are giving to our structure. I deeply thank to all colleagues that have embraced the cause, and especially for the colleagues from Fogarty da Madrugada. They have an Instagram channel with very nice publications using the draws for making more attractive, and they have developed this very nice draw for us. And although we've been having very nice online meetings, I really appreciate, but I really want to meet some very nice and very good colleagues in person so that we can have a toast about everything that we've been discussing. Thank you.
Thank you so much, Fabricio, and congratulations for having brought science into this topic that is really needing that. And I hope that soon I will receive also a mug that I haven't received yet. So now we start the scientific word round, where, as you know, we invite keynote figures to give us their perspective and a revision of the keynote lecture you have already enjoyed. So it's my pleasure to fly all the way to Russia with Eugene Bereznoy, a dear friend of the Viewing Foundation, involved also with our humanitarian mission. Eugene is a great expert in laser. So Eugene, please make your question to Professor Santiago.
Hello, dear colleagues and friends. It's a big honor and also big pleasure as well to be involved into this amazing humanitarian education project. Deeply thanks for this for all organizers, Oscar Battini, Willie Chi, and Sergio Giannazzini. My congratulations for you, dear Fabricio. Your presentation was excellent. My question is, currently, where no accurate recommendations and guidelines regarding optimal diameter of reticular veins when transdermal laser 1064 nanometer can be used. Some authors say it should be anywhere between 1.5 to 3.0 millimeter. What diameter of reticular vein would you optimally treat with this laser? Or what main criteria you will use to select laser power? You will look at the vein diameter or vessel type, red or blue, or depth vessels. Thank you.
Wow, Eugene, thank you very much for your questions. I don't know if I will have time to answer all of them, but regarding, this is a very, very nice question. Regarding the choosing of the, really it's not power, but it's energy. But really, we do not have cutoff points for treating reticular veins. We have some publications. If I'm not mistaken, we have a publication from 2003 from, I know, I'm not sure, but Dr. Omura showing that they had very nice results treating 3mm veins, for an example. But in daily practice, we have some limitations. First is when you decrease the vessel diameter, you have to use larger post durations, and also you have to increase a little bit more your energy. The patient will not tolerate the pain. And if I can tell you a cutoff point, I can tell you that, for an example, as monotherapy, we're not talking about association of techniques right now. We're talking about transcutaneous lasers. I can tell you that until up to 2mm, we have very nice results with monotherapy for reticular veins. Above that, probably the patient will not tolerate the pain, especially above 3mm. And you also have the problem of microthrombi. So anyway, regardless of sclerotherapy or laser, transcutaneous laser, you have microthrombi, so you have to do use a very nice extrinsic compression, so you don't have microthrombi. So you do not have this cutoff point, but probably would be 2mm with optimal results without having side effects, just as pain and microthrombi. Regarding the other questions, I'm going to send you and text you, so I can answer you properly, and to the other colleagues as well.
That's a great idea, Fabricio, and thank you, Eugene. Indeed, it's a chance to remind everyone you can make your question in the question and answer box, so they will be answered live or in written form. Now it's my pleasure to leave the mic to Professor Chi to fly all the way to Latin America and introduce the next continental expert representative. Willie?
Yeah, next we have a great personal friend and a friend to VWin, Marcelo Grill from Central de Estudos, Hiroshi Miyake. Marcelo?
Hello, Willie. Hello, Fabricio. Are you listening to me?
Yes.
Yes.
So, Fabricio, your lecture was really, really clear. And in the matter of techniques association, which one we should do first, the laser or the sclerotherapy?
Very, very nice question, Marcelo. Once my chromophore is going to be the hemoglobin, I prefer to use, according to the laser physics and the principles of selective photothermolysis, I prefer to use the laser first. And after that, using sclerotherapy. As I mentioned in my slide, we have some other techniques using first the foam, and after that, using the laser. But as you can notice, the chromophore is going to be the bubbles, not the hemoglobin. So I prefer, according to the physics and the development of the laser for treating lag veins, to use first the laser. And we also know that, for example, the Clax technique, we do not intend to that the vein disappears. We intend to use a low profile laser so that we have an edema of the media, and then we inject just a few volume of sclerosant agent, okay?
Thank you so much, Marcelo and Fabricio. And now we fly all the way to Italy, thanks to Professor Bottini, who is introducing a dear friend of mine and also our continental expert representative for Europe. Oscar?
Thanks, Sergio. Let me introduce Dr. Demetrio Guarnacchia, President of the Italian Association of Phlebology. Demetrio?
Demetrio Guarnacchia?
Senti, okay?
Yes.
Allora, congratulations for the good presentation, Fabrizio Santiago. Congratulations, Sergio Gensini, for webinar, good interesting. For the treatment of aesthetic vein for laser is so important. Knowledge of different type of laser, have different type laser available, extensive laser experience, choose the right patients of treat. One question. Despite the literature at our disposal, do you think that grade 1A for the treatment of leg vein according to guideline from the European Society for Laser Dermatology, with laser 1064 is appropriate. According to the European experience of phlebology, the best treatment in terms of efficacy and safety is the sclerotherapy. What do you think about that, Fabrizio, please?
Very, very nice question. Thank you for this question. This is very important because when we look at the recommendation gradings, it's very important to know the scientific background for that. And I agree with you with that, because when you see the literature that has been referred in this guideline, for example, we know that is not totally consistent, but we have some literature supporting that for treating leg veins, especially the reticular veins, we have some very good scientific background. And as I showed you in the slide, we have this review, is not yet published, but they allowed me to show some previous results. There are no differences between the efficacy when we're doing when we're using treatment, laser treatment, and comparing with sclerotherapy. I mean efficacy, okay? So sclerotherapy for most the authors and most guidelines is still the golden, the gold standard for treating leg veins. We have no doubt about that. This is true. But as I mentioned, if you're trying to use laser for treating your patients, I do not advise you to buy just to treat leg veins. You need to treat in association, and you need to explore your laser more to use for other indications so that you can explore your device the best that you can, okay? Thank you for your question.
Thank you so much, Dr. Guarnacho and Fabrizio. It's my pleasure now to fly all the way to North America with a dear friend from the American Veins and Lymphatic Society and also the University of California, San Diego, Professor Vineet Mishra, a great expert on the field. Vineet?
Thank you so much for the invitation to be part of this. This is my first time. Wonderful lecture. First off, just had a couple questions about nasal veins. I have had some difficulty in treating nasal veins because I find that A, they tend to come back, high rate of recurrence. B, sometimes the veins don't respond. I've used KTP 532, I've used pulse dye, Nd:YAG. Any tips or tricks for the audience on how to treat nasal vessels, which are high flow?
Yes, this is a very nice question. I have the same difficulties that you have. In the cases where we do not have a good response with the 1064, we tend to use the IPL. It's some very nice results, especially those tiny telangiectasias. But you know better than me that the problem with the telangiectasias in the face, it's also related to sun exposure. So patients usually have a recurrence because of they are exposing their skin to the sun without the appropriate protection. So this is something that occurs not only because of the hemodynamics problem, but also because of the laser exposure. So if I'm not having good results with the 1064, I really recommend you to be really careful with the 1064 in the nasal veins, because you can cause a real problem with that. I advise you to use shorter wavelengths, just like the KTP, and we've been using the IPL with very good results. And you also need to tell your patients, lower your patients' expectations. So you need to tell them that that can come back, that cannot be treated as expected, okay? Thank you for your question.
Thank you, Vin, and thank you, Fabrizio, and deeply thank to all the continental experts involved in this World Scientific Round. And now it's time to leave the mic to the audience, Fabrizio. And we are looking at the questions we have received more likes, and we start from a Spanish-speaking colleague. So we try to translate for you the question of Sergio Rix Castro, and he's asking you if it is advisable to treat first the reticular veins by sclerotherapy and then the telangiectasia by laser, and how to avoid pigmentations after transdermal laser. And Professor Prego from Uruguay actually replied already with absolutely. So let's see if you agree with our friend Alfredo.
Okay. I really like to treat, we have a problem that usually the patients come to the office, they are willing to treat everything in just one time. So I really treat the reticular veins, and after that I treat the telangiectasias. We have some colleagues that prefer especially using sclerotherapy, that they are used to treat the reticular veins that are so-called feeder veins, that we know that this is not the real concept, but and after that they treat the telangiectasias. We usually use to treat just one time. And the second part of the question was?
How to avoid the pigmentation.
Oh yeah, usually a transcutaneous laser, especially in the reticular veins, what we see is some contraction of the vein. We do not have a lot of microthrombi when the parameters are right, and I tend to use when the veins they are above 1.5 or up to 2 millimeters by using eccentric compression along with compression stockings during 24 to 72 hours to avoid this kind of complication if I'm thinking that is going to occur, okay?
Thank you so much for the question from the colleagues and also for your answer. Now we move to the second question, Fabricio. Isabella Giardulli-Sichman is writing, hi, very good talk. So if the patient has telangiectasia that would have an excellent results with conventional sclerosis, would you still do laser?
Yes, because I have it. So I always use laser first because as I showed you in that video, when we have a total disappearance of the telangiectasia, I don't need to inject anything else. I don't need to do anything else. So this is because I have the laser with me. So I tend to use the laser as much as I can. And CLACS is my preferred technique for treating C1, not a complicated C1 patients with very nice results. Some comparison results there in Adducto, we don't have the appropriate randomized controlled trials for that, but in daily practice, we see that the results are really good. I prefer to use laser first, and we do not have any result. And after that, I use this sclerosantagin.
And then we move forward for the last question, and maybe the colleague knew that you are one of the authors of a very interesting paper on this topic. Let me translate for you from Italian. How would you suggest to document telangiectasia before and after the treatment?
Very, very nice question. I have a concept that I call so-called the curtain effect. If your patient is standing, you can see bulging veins more appropriately, and this is the time that you need to take pictures. Otherwise, if you have reticular veins and spider veins, the patients need to be laid down. So this is because the skin have some cumulative layers. When the patient lies down, this curtain effect, it disappears. So it's more clear to take pictures from telangiectasias and reticular veins with the pain in the lying position, okay?
Thank you so much, Fabricio, and also Dr. Parisella for the question. And now we are finishing this first session of the webinar. I hope you could hear all the people clapping you. We are like hundreds and hundreds of people here. So thank you so much, Fabricio, and all the faculty involved so far. And now it's time to move forward for the second part. And as I had to introduce Fabricio as Michael Jordan, I had to find an equally great sport professional in honor of India. So Nandra Joig is a great squash player in honor also of the good squash moments we had with our master of squash, Professor Sriram Narayan. Rahul Jindal indeed is one of our champ. He's coming from the Punjab University. We all know him as a great innovator and also educator. And we personally know him as a wonderful example of professionalism and a human attitude during our We Help missions. So Professor Rahul Jindal is getting ready to give us his talk about aesthetic lasers in phlebology, possible complications, and their management. Rahul, thank you so much for being here and ready to share your screen. Can you hear us, Rahul?
Yeah, I can hear you.
That's
Good
great.
evening. And Sergio, thank you for introduction and thank you for giving the part. I'm just going to go through an aesthetic phlebology. What are the possible complications and management? You see, that talk would not have been complete without the help of Professor Goldman, Kasamiaki, Giovanni, and patients and Fortis Hospital. I really acknowledge them, all of them, in preparation for this talk. We all know about the C classification, and we are going to cater mainly the telangiectasias and the reticular veins, the C1 in my talk here. We know about that if you have a huge varicose veins like this, you get a fantastic result with the laser and the sclerotherapy of lobectomies. What we don't still have the gold guidelines for the reticular veins and telangiectasias. You know, reticular veins are the veins which are behind, it's below the skin, it's subdermal. They are 1 to 3 millimeters as compared to telangiectasia, which could be red and blue, and they are 0.1 to 2 millimeters, and they are in the dermis. So that's the basic difference between these two veins. And there are various methods which we have already seen, being getting into Cochrane review to treat this group of veins. And we also know Clark's procedure, which has been just mentioned by, Kasio Miyake, and, he's really doing a great work. And I think we really need to do a lot of studies to see that the plain sclerotherapy and the Clark's, where do they stand in the future? So we need to have a Flabo suite. And the most important thing is that if you make the patient stand and if you see that the patient has got a lot of veins, you need to do a preoperative duplex scan to see the perforators or the depot veins has got a refluxing veins or not. So you can do the laser procedure here. And once you do the laser procedure, and you can use the different spot sizes and all, we are going to discuss that later. And after that, you can inject a sclerotherapy. In here, we are injecting a 75% dextrose into the vein under augmented reality. So you can get a very good results if you do the procedure properly in this group of patients, especially in the foot veins, which really only a plain sclerotherapy may cause a skin necrosis, especially the veins which are nearly in the epidermis. Now, this picture really shows that you should not treat the telangiectasia and reticular veins directly without missing the deeper reflux. So because you must treat SPJ or SFJs or perforators before you embark on the C1 veins, because what we have observed is that if you treat the deeper refluxes, and in the future, if you observe them 2 to 3 months later, a lot of these veins, sometimes they disappear and the patient does not require any treatment. Now, this is the results what we want. Whatever treatment or methods you want to use, but we definitely don't want this. A skin burn, a pigmentation, a scarring, definitely not. So we are going to place this talk into two complications because of sclero and complication because of laser. There are a huge amount of complications which can happen from sclerotherapy. We are just going to go one by one. But the major causes of this is insufficient delivery of drug, high concentration and pressure, and imprecise injections which are there outside the lumen. The most common complication is in hyperpigmentation. And normally it disappears within 6 months to 1 year, but it can persist in 1 to 2%. And if you could look into the percentages, dextrose and glycine causes the least hyperpigmentation. The pigmentation can be linear or punctate, and a lot of causes which has been documented why you get this pigmentation, because the patient has come for cosmetic region, the pigmentation is not a very good idea to have. So the basic concept is less inflammation, you will get less pigment. So use a sclerosant which are lighter, and foam is stronger than the liquid. So if you have to use foam, use a lower concentrations. Technique is very, very important. We should always limit the pressure by which you inject into the vein. Look into the syringe size. You have to understand 2.5 ml syringe or a 3 ml syringe will inject at a lower pressure as compared to a 1 ml syringe. And this is a basic physics. Similarly, you will get more pigmentation in the legs as compared to if you treat the hands. Because of the gravitational pressure, you will have an extravasation of the RPCs. Similarly, a blue leg telangiectasias will cause you more pigmentation as compared to the red vessels if you treat them. Dark color or Asians, they are more prone. If the patient has got a higher serum ferritin level, you get more pigment. So therefore, you should avoid an iron supplement for 1 month for this group of patients. If your patients previously had an hyperpigmentation, try to use an antihistaminics, into the perioperative procedures, and try to avoid doing the procedures in the perimenstrual or the ovulation period of the female. If the patient is on drugs, something like a minocycline, then you should see if the patient can stop this drug when you are doing a sclerotherapy. If the patient has got a coagulant, try to remove them because that can cause an inflammation and result in pigmentation. And also important is how you inject. So there are a lot of guidelines and procedures, how do we make an injections, but when we do the injection in this plain sclerotherapy, we use a 30 gauge needle with a wibble up, we bend the needle a little bit, and this is the procedure. We puncture the skin and maintain a small pressure on the plunger and try to inject the needle into the vein. I've just put in a small video just to show you what I mean. So what we are using is a very dilute sclerosant foam, 30 gauge needle, a band-in, and I'm just putting a small pressure on the plunger and trying to move forward gently into the telangiectasia, very small. As soon as I'm inside it, so you can see the whole telangiectasia that disappears. And if you are injected properly, then there is no extravasation. And if you follow these patients up, these patients will have very good results. In terms of treatment, if it really persists, mostly we do conservative. You can use some drugs like a 20% TCAs and retinol creams. Compression for treating, after treating spider veins, there are still controversies in the literature. We still don't know. But if you have an hemocytin pigment, which is outside the vessel causing a pigment, it is very susceptible to 410 to 450 nanometer. So we can treat it with the lasers. We can use a pulse dye, we can use an IPL, and we can also use a ruby laser, and we can also use an NDY 1064. All these lasers can help us in removing the pigment if you have a pigment which is persistent more than 1 year. We can get a temporary swelling, which is more in the ankle because of the gravitational pressure. We can treat it with local steroid creams and compression. Matting is a very important complication. It is appearance of the new fine veins, which happens after sclerotherapy in a different area. So why it happens is if you cause more injury, you will get more ischemia, you will promote new vascularization. This rarely happens in the face, hand, and chest. And age, male, and standing for a longer time does not predispose to the formation of matting. Normally, it can occur in few days to 3 weeks. It's persistent more than 1 year, only in 2 to 3%. That's good for us, but less inflammation, you will get less TM. So therefore, if you use a dilute sclerosants and if you compress the veins, then will be less thrombus, you will get less matting. If your patient is prone to TM, then there are a few things we can do. We can inject a protamine along with the sclerosant. We can use a pentoxifylline. We can use an H1 inhibitors. And if they are still persisting, we can treat them with an NDY 532 nanometer laser. Some of these patients can also have pain, especially if you inject in ankles, feet, upper medial thigh, and medial knees. But the important thing about this is when you are using a dilute STS, this is the agent, if you are going to inject outside the vessel, is going to pain. But if you are injecting in the vessel, normally it does not pain. So which is a very good marker, because if you're doing it without local anesthesia or a cream, so that because you can know that you are exactly inside the vessel and not outside the vessel. You can get a tape blisters, you can get folliculitis, especially in Asian countries or tropical countries. Now, recurrence. Recurrence normally happens, in the reticular veins because you can form a thrombus and it can recanalize. But normally in the telangiectasia, the vessels are very small, so you don't normally form big thrombuses causing recanalization. So normally these veins are new or the leftovers. You can get a cutaneous necrosis, especially if you come because of extravasations and arterial injections. So that's why you need to know exactly what concentrations you are going to use when you're going to treat these veins and how much volume you're going to put in. But important is that the glycerin as the dextrose, you really get much lesser cutaneous necrosis as compared to the other detergents. You can also get an NLD, and that can occur at all concentrations, especially in area which has got rich arterial networks. Intra-arterial injections. This is important because 10% of the telangiectasias, they are associated with AV shunts or dermal arterioles. So that's why if you use a higher viscous drugs like glycerin or a dextrose, the chances of this will be much lower. Coming to if you get an extravasation, what should you do? You can either, if you put in too much extravasation, which should not happen in an experienced hands, you can still dilute the sclerosant with saline injections, or you can put in a hyaluronidase. I put in the doses at multiple sites to dissolve the sclerosant and it can get diffused. You can treat the cutaneous necrosis just like any other skin damage, and it normally heals within 4 to 6 weeks. You can get multiple allergic reactions like a localized urticaria, which normally disappears within 30 minutes. You can get a systemic reactions. Very important to differentiate anaphylaxis, which has got a heart rate increase, from a vasovagal reactions, which will get a bradycardia. So because this is very important and this can happen. So we have 3 patients in the last 20 years who had these reactions. Coming to allergic reactions with an STD, it is slightly higher than the polydocanol, but not huge. It's around 0.3%, and it normally happens because of the impurities which are there in this drug manufacturing called as carbitalol. Polydocanol, the incidence is around 0.01%. It is much lesser. You can also get a thrombophlebitis, and normally it's get because of the lack of compression or significant reflux into the treated vein. It can be treated with an NSAID, so you can take the blood out, and once you've taken the blood out, there'll be less inflammation, and this infection will settle down. Especially in the perimalleolar area on the medial side, if you get a lot of veins there, then you have to be very careful, because especially in thin patients, the posterior tibial artery is very, very close. So sometimes you can put an injection into this. So you have to be very, very careful what you're doing there. Then you get a lot of neurological events you can get. You can get a stroke, very, very, very rarely a death. You can get a nerve damage with the direct injections. You can get a migraines or headache, which are normally really temporarily, and they disappear with time. Very rarely you can get a DVT. Up to 13% of the patients with telangiectatic veins, they are at risk of spreading the sclerosing solution into the deep venous system. But the dilution, what we use of the sclerosing in the veins, in these veins, and the amount of volume what we use normally should not cause you deep venous thrombosis unless you are injecting a huge amount and in higher concentrations. If the patient is on OCPs, you should try to avoid to stop it. If you cannot stop it, try to change it to transdermal estradiol rather than the oral, because that can bypass the liver. Tamoxifen is another very common drug, because these days when these patients come for sclerotherapy, you should be careful while you are doing the sclero in them. As pregnancy, you should try to avoid them at least up to 6 weeks after the delivery. Rarely you can get an air embolism, but in a French study of 6,400 patients, 16 episodes happened of eye symptoms when you are treating C1 veins. So the incidence is low, it was not permanent, and all this disappeared within 15 minutes to 6 hours. You can get a scotomas in some patients, but they are all temporarily. If you look into this study by Professor Goldman, it shows that STD versus polydocanol, you got a similar efficacy and similar adverse event. There are a lot of such publications which are there. And there have been a lot of publications which had shown that if you are an experienced person, any sclerosant you use, you can get a similar results. There are two very important studies published on Clark's. These are the largest series published by Kasumiaki, which shows that 86% of the patients get satisfactory result, of very minimal complications which are less than 1%, and there are no major complications which happens if you treat these C1 varicose vein patients. Coming to the complications with laser, the important thing is when you're doing the laser, you must know how much to do it. So if you get a bluish or grease discoloration visible on the skin surface, and you're getting a blanching or disappearing, you should stop. Don't keep on doing it more. There are a huge amount of side effects which can happen, and they are normally happening because you don't know your machine. They're like pains, purpura, bleeding, swelling, and you can get blister formations, you can get an infection, especially if the patient is giving a history of herpes simplex, like maybe 5 to 6 episodes in the last 1 year. Then if you treat the legs with a laser, then there could be a reactivation, so you can start a prophylactic acyclovir. You can get these patients with a hyperpigmentation, more in patients with darker skin types, but normally it fades off within 2 to 6 months, but we can use the topical bleaching creams. You can get complications like a skin lightening, skin texture changes, and scarring. Normally they are happening because you are damaging the collagen surrounding, and you are passing on the heat more than what is required. And the persistence of the lesion is one of the major side effects, what we were discussing on the facial veins. This is a problem with the lasers. Post-care, you can, if there is an erythema of burning, you should use an ice packs. You should avoid a sun exposure for around 24 hours. You can use an SPF creams. Non-irritating soaps can be used to wash the areas after 24 hours. You should avoid the swimming or prolonged bath. And leg vein result, we must wait for 4 to 6 weeks for it to be noticed. The contraindications have already been covered, so I will not come again. Now, this is one of the very important slide, I feel, last 2 slides. When you're doing the laser, the important thing is you see the smaller vessels, we should the shorter pulses. If the depth of the vessel is more, then you should use a larger spot, longer wavelength, and longer pulse with cooling. If you have a darker skin, try to use a longer wavelength so it can go deeper, and longer pulse intervals. And try to use, if you're using an overlapping, less than 10% to decrease the scarring. And there is something called as stacking. So what if you want to pass on a higher energy, so you can put in 2 stacks rather than giving 1 higher energy shot. So that will decrease the pain and also causes less heating damage to the surrounding tissues. If you are treating the fragile areas like bones, use less energy. I feel the pulse duration is still very important. There has been 1 or 2 publications which shows that this is not the important thing, but I still feel that if you are starting the laser and you are really not know, then this is a very important safety feature, because how much duration, the heat, the laser energy you're going to give it. Because if you put in too much energy into the system, all the complications of laser will happen. So for that, I still feel that TRT is very important to have a basic understanding that if you are treating a very small microvessel, your pulse width should not be more than 20 milliseconds. But if you are treating a C2 varicose veins or something like reticular veins, then your pulse width can be kept at 15 to 30 milliseconds, up to 50 milliseconds in a 2 millimeter vessel. The 2 important things, I feel the consent and the photographic documentation is very important. And this is a very important slide that if you are treating telengiectasia, very superficial, then you should use a short wavelength, short pulse width, small spot size, and low fluency, and vice versa. So this is the last slide, I think, and which lasers you use where. So if you have a less than 1 millimeter, you can use a KTP, which is a very superficial laser, and it's a 532, and you can use an FPTL, you can use NDVAG and IPLS. But if you're treating reticular veins, you can use larger diameter deep leg vessels. You can use NDVAG, alexandrite, diode, and IPLS. So in conclusion, both sclerotherapy and lasers can be used in the treatment, but you should have the proper knowledge, and technique is the basics to prevent complications and get good cosmetic results. Thank you.
And thank you so much, Raul, for another wonderful lecture. So if you can stop sharing your screen, we'll start the World Scientific Round immediately with Brazil. So it's my pleasure to introduce a dear friend, Rodrigo Bono Fukushima from the Miyake group. And Rodrigo, the mic is on you now for the question to our friend Raul.
Hello, Sergio. Thank you again for the invitation. Thank you, Raul, for this magnificent presentation. So we all know that hyperpigmentation is one of the most common complications we all have in our office. So regarding hyperpigmentation and its pathophysiology, in your opinion, what would be the rationale for choosing the sclerotherapy technique, considering variables such as the type of lesion and the treatment region?
You see, hyperpigmentation normally happens because you get an RBCs which goes out of the vessel. So it's important is, so if you are using a sclerosant, anything, you know, all these telengiectasias, as you know, they're very thin vessels and you get an epidermis inside. So if you use a very high irritant, this basement membrane will get destroyed, the RBCs will go out. So one should use a dilute sclerosant, and one should use compression if you're using a reticular veins in this group of patients to prevent an inflammation.
Okay. Thank you so much, Rodrigo and Raul. Now we fly all the way to Europe, and it will be Professor Chi honor to introduce our continental expert representative. Willie?
Yeah, next we have Dr. Oren Solario to give his question from Romania.
Sorry, are you with us? You are muted.
Can you hear me?
Yes. So we have with us Professor Oren Solario from the University in Romania, President of the Romanian Society of Phlebology.
Thank you for inviting me to this excellent webinar, and Sergio, congratulations for this organization. And I have 2 questions, small questions. First of all, I would like to congratulate for this excellent review through sclerotherapy. And my first question is, what do you use in telangiectasia, foam or liquid? And the second one, what is your opinion about sclerotherapy in upper limbs, because not point of view aesthetic but legal, because you destroy the venous access to the treatment.
Sure. I think these are very important questions. The first of all, if I'm using the telangiectasias, so I need to know how much area I have to treat. So if I'm treating a very small area, I use a liquid, and I use 1 to 5 liquid. And if I'm using a very big areas, then the volume of liquid is quite a lot. So then I try to use a foam. But when I'm using a foam, I dilute it slightly more as compared to what I'm using the liquid. So if I'm using a liquid, let's say 0.25, then I will dilute it by 50% more and then make a foam of it. So actually talking, I'm making a foam of 0.12 or 0.15. And then I think concentration is one important thing, and the amount of fluid what you're injecting is very important. So I don't push the fluid. So I just keep a small pressure on the plunger. As soon as it flows into the vessel, I see the disappearance of the vessel, I stop. So as I can show you in the video. Coming to the hand veins, I don't inject much. I do very rarely, only if the patient really pushes me. And if the patient comes in, I actually normally send the patient back at least once, so that the patient goes home, thinks about it again, at least twice, and I try to discourage the patient and try to show my hand veins also that this is normal. But you do get patients in the peri-marriage area, because some patients have got really very prominent hand veins, and so that's the only patients we inject, but it's not very common. And if the patient has do it, so video consenting is the most important thing in this group of patients. Yes.
So we thank you a lot, Professor Olario, for his participation, and also Raul for the answer. And now it will be Professor Bottini honor to introduce another friend from India.
Thank you. Let me introduce Dr. Shoaib Padaria from the Venous Association of India. Shoaib?
Shoaib? Can you hear us? I see he's here.
Okay, yeah.
Yeah, here you are.
Oscar, thank you very much for the introduction, and also thank you, Sergio and Willie, for having me on this wonderful platform. Raul, a fantastic, comprehensive review of everything to do with sclerotherapy and the complications, very informative. As you all know, I come from the city of Mumbai, which is the center of the film and television industry of this country. And the last 20 years, I've been treating a lot of the film stars and TV personalities with sclerotherapy for their spider veins and telangiectasia. A small percentage of these patients do suffer from significant pigmentation, which can be long lasting. And this is a catastrophe for us. So what I would specifically like to ask you in this regard is that how do we minimize the risk of pigmentation in these patients? One, by which sclerosant should we use? Two, what is the exact minimal concentration of sclerosant that we should use? And thirdly, are there any specific medications which we should use before and after the procedure to make sure that they don't get pigmentation? I wouldn't mind repeating the procedure in these patients, but to avoid pigmentation at any cost.
Absolutely. And that's why I put in the first complications as hyperpigmentation. The good thing about that is that if you tell this patient before the procedure that if you will get the hyperpigmentation, that this will disappear between 6 months to 1 year. So this is a very important thing. And in my consent form, hyperpigmentation is at the top in terms of complications, because a lot of these patients, they come for cosmetic problems, so there is an issue about it. Now, how you can decrease it? I always try to use the dilutional form, the most dilute I can use. So if I have to use a blue or the red telangiectasias, so maybe as I said 0.12 or 125 or 0.25, not more than this, if I'm using an STD, because that's the only, we don't have the polydocanol available, the drug in our country, so I'm using an STD. So I will use a very dilute an STD. So we already got a 75% dextrose. So I will use a very small amount of dextrose. So if you look into my slides, dextrose and the glycerin got the lowest incidence of hyperpigmentation. But there are some publications which have shown that the hyperpigmentation rate with very dilute STD, polydocanol, and glycerin dextrose is similar. Second is what you can do is that conservative treatment if the patient gets a hyperpigmentation, but you can also start this patient if the patient has got propensity, then you can start this patient with antihistaminics, perioperative for 1 week, because that decreases the inflammation. That has been, there are some publications on that. Then you should also use, these patients should avoid sun for some time. You can also use an SPF creams, which should be started. There are some publication which shows you should start the cream 3 weeks before the procedure in the areas where you're going to do it, and continue that for another 2 weeks after the procedure. So, that will, sun protection cream with a factor 50, that is another possibility. And I feel the most important point is the technique, because if you have an extravasation of RBCs while you're doing it, I've seen a lot of people doing it, then that really makes a difference. And also use the thinner needles, because thinner the needles are, then the chances of extravasation of RBC will be much lesser, and a lesser pressure, and a 3 ml syringe.
So thank you so much, Shoaib and Raul. Now we go toward the conclusion of the World Scientific Round. We conclude the big with Dr. Marlin Schul, President of the American Veins and Lymphatic Society, a dear friend for many of us. Marlin, the mic is for you.
Good morning, everyone. And again, thank you, Sergio, Oscar, and Willie for the kind invitation. And it's great to see everybody here. I echo Dr. Fabricio's and I think all of our willingness to actually meet in person when the time permits. My question, number one, congratulations on this talk. It was a thorough discussion of the various treatment options and complications from vein treatment. Do you believe experience plays a role in reducing major complications from small vein treatment? And if so, how might we work to bridge the knowledge gap so that new providers entering the field are delivering optimal treatment with safeguards for our patients? I'll wait to hear. Thank you.
Sorry, can you just repeat it? I should not, I think I have got the question wrong. Please, if you can repeat it, please.
There are a lot of people that are entering the specialty of managing patients with veins. The question was, does experience play a role in reducing major complications? And if so, how can we bridge those gaps to make sure as new people enter the field that they're still providing safe treatment and delivering outcomes?
I think it's a fantastic question. And I think if I see the whole talk and everything, the most important thing, if you want to avoid the complication, both with laser and sclero, is the training. Is the training. I have seen hundreds of people using the wrong doses, wrong concentrations, wrong syringes, wrong needles. And most of them, they're using the laser machines without even actually understanding the basics of laser physics. They actually, I have seen in the groups getting discussions, should we use an IPL? Should we use an KTP? Oh, I think this vein, reticular vein, we should use a KTP. You don't understand the KTP will not be able to reach there, the basics of the physics, laser physics. And I think anybody who wants to get into this, they should have a very basic knowledge. It's a very vast, and it is not that simple just to take a syringe, make a foam, and then just inject it. People feel it is very simple. It's actually, if you feel it's simple, then you're not going to get the results. That's the problem.
Thank you so much, Marlin and Raul. And now, again, we deeply thank all the Continental expert representatives involved in this round. And we welcome the questions from the audience, Raul. So looking at the question and answer box, I was getting worried because she wasn't appearing yet, but now we have her on podium again. Our Cleopatra of phlebology, Wasila Taha, is asking you, she's writing, great talk, dear friend Raul Jindal. As we are all still in the pandemic time of the mentioning COVID, are there some instructions or precautions to consider in the context of the sclerotherapy?
And of course, thank you, Vasila. And, guys, COVID is an inflammatory disease. And, a lot of publications are there that it really increases the chances of having an arterial and venous occlusions. So that's why if you are using a huge amount of sclerotherapy, and I think if you're doing a lot of procedures on the deep venous, you will get more chances of getting a deep venous thrombosis, because we are getting a lot of patients who are asymptomatic and they are COVID positive. So if your clinic is not doing a COVID test in all the patients who are incoming and you're doing a sclerotherapy, then you should be a bit careful and should keep a very close watch on these patients developing a deep venous thrombosis.
And I take this chance to invite everybody to enjoy the recorded video lesson of the webinar we took on sclerotherapy and COVID to have a deeper look on this topic. Now we fly all the way to Mexico with our friend Ignacio Escotto asking and writing, fantastic presentation, congrats. What is your preference for the position of the leg during sclerotherapy? And if this influences the microthrombosis of reticular veins and telangiectasia?
Yeah, this is a very important question because there are a lot of people who sometimes they don't inject it while lying down. So they put in the needles, put in the scalp veins while the patient is in a standing position, and then they make the patient spine, and then they make the patient leg up, and then they inject it. I personally don't do any of these things. I make the patient spine. If I'm just using telangiectasia and spider veins, so I actually don't even do the Trendelenburg position and make the patient supine, and that is more than enough, because the moment you use the cool air on this, all these venous systems, they get into spasm. So you don't need to actually raise your leg because that makes the patient uncomfortable. But if I'm using a huge amount of C2 varicose veins and I'm doing the sclero, then definitely I like to do Trendelenburg position and leg up, and while I'm injecting and with a pressure so that there is least amount of blood in the vessels while I'm injecting the foam.
Thank you so much, Raul. And now we have a question from Annelise. There is no surname. I guess it's Rodriguez from Brazil. And the question is, Dr. Raul, considering the possible known complications of the procedures, how do you deal with patients' expectations, especially about aesthetical outcomes?
Yes, and this is the most important, and I think the best thing you can learn is from Kasumiyaki in this, because he takes two important things. One is the consenting. So most of the patients for cosmetics, we are doing a video consenting, and second is the photographic documentation. So if you have a photographic documentation before and after, and second is if you're taking a proper consent, so normally you should not have a problem. But if some patient is very finicky, if you would have see my slide, I put in a contraindication to the cosmetic procedure if the patient is really very finicky, because then you have to be very careful, because one of the most this is one of the most litigated procedure in the world. So you have to be very careful what you're doing.
Thank you, Raul. And now we have a question from Professor Lowell-Kabnik. We all know him. What about the use of Deflon? Do you see less pigmentation with those that are on statins?
Really, personally, I don't use Deflon in this group of patients at all. I use Deflon very sparsely, and especially only in patients with venous ulcers. And regarding statins and pigmentation, I have not come across any correlation personally. So in my practice, I'll not be able to comment on that. Is it more or less?
Yeah, there are some interesting studies coming out, but just recent on venous active drugs like surodexide that are acting on the pigmentation in sclerotherapy. But I think this opened the floor to analyzing evidence-based data in aesthetic. And this would actually be my question to you and also Fabricio. We have been all involved in last winter document analysis of the global guidelines. And if you remember, we were pointing out 3 months of maximum follow-up in aesthetic phlebology papers. What is your feeling about the shortest follow-up we could consider valid before considering the results reliable in aesthetic treatment?
I think 3 months is required, not less than 8 weeks.
Fabricio, would you like to comment on this?
Yes, but I have not the answer for this question. But I think 3 months is going to be good, because we all know that the venous disease is progressive. It will never end. So, but I think in terms of follow-up, 3 months are if we're thinking about hyperpigmentation when we're following up these patients, we need to wait until 6 months. So 70% of hyperpigmentation disappears until 6 months, and 100% until 1 year. But I think 3 to 6 months.
And indeed, since we are always trying to focus on evidence-based data and fake news-free information, I think it's also important to point out that it would be pretty impossible for a US colleague to answer to the question related to MPFF, because they don't have approval for that same for UK. So that is another gap I think we should cover in the future. Do you have some opinion on this, or Raul?
So MPPF, we have been using Teflon for such a long time, and
But what I mean is that they cannot use that in US. It's not approved. Same in UK. So we have sparse data on this. So it's another gap to close.
So there will be a problem because we don't have actual data. But in our clinical setups, what we have seen is that that we are not using this drug in especially cosmetic purposes. But yes, varicose veins, venous ulcers, yes.
It would be interesting, I think, to see if these venous active drugs like MPFF, who have demonstrated venoactive roles, can decrease the venous hypertension to a level for which you can improve the aesthetic result because of that. But up to my knowledge, we still have to work on that. Do you have a comment on this? Because technically it has been demonstrated you reduce the venous hypertension. So if you reduce the venous hypertension, potentially you could have a better result. But
theoretically, yes. Theoretically, yes, it makes sense. And but practically, I don't know.
It is. So very last question from Italy. Let me translate this for you. Maria Parisella is asking you, which kind of tips and tricks could you give us on obese patients before laser treatment of telangiectasia? Do you have some tips and tricks for obese patients with transdermal laser? If you understand what I mean, Raul?
Yeah, I understand. Yeah. But it's sort of similar because especially in the obese patients, if the veins are, in the superficial, in the epidermis, you use in the same way. And if they are reticular veins, sometimes you have to use an ultrasound. Sometimes they are not visible within, naked eye. And then in that group of patients, because especially in the obese patients, when I'm treating telangiectasias, I make sure that I do an ultrasound in that area to make sure that there are no perforators, because in thin patients, you can see visibly the reticular veins. But in obese patients, sometimes you can miss the perforators to the telangiectasia. So I think, and as you know, it's very important to treat the perforators and the reticulars before you treat the telangiectasia. So that is one of the important things I would like to do in this group of patients.
And thank you so much, Raul, and also Fabricio. We are closing up the scientific time, and we're going to wrap up the take-home messages. I'm always surprised. I'm used to know the quality of your talks, but I'm always surprised to see that you always beat yourself. So thank you so much for this wonderful contribution. And now it's time to give the mic to the honorary chairs. Unfortunately, Professor Goldman is having technical issues in joining us. He delivered his recorded video lessons in the platform, so you can enjoy that over there. It's my deep pleasure to introduce a master of the field, Professor Kikuchi Rodrigo from the Vascular Excellence Clinic in Brazil. Rodrigo, if you want to share your screen, if you have some slides, we are looking forward for taking on some messages according to your suggestions.
Okay, right. Thank you, Sergio, and thank you all. Congratulations for the work. Thank you for the invitation to make some comments on both presentations. Of course, it is very challenging to treat telangiectasias. You all can see that. But first of all, both of the presenters, they said that it's paramount to look for the source of the lesion, even to treat or to avoid complications. But I want you all to remember that sometimes it's not only the ultrasound or the augmented reality or phleboscopy that will show us the source. We need to look a little deeper or shallower to the skin, because we do have, it's described very for a very long time ago, that we do have two horizontal lines of circulation, and one is controlled by like sphincters, smooth muscle cells. So it's kind of different way to think and a different way to treat. Also, nowadays we're looking for different physiopathologies on telangiectasias. And as Sergio said moments before, maybe the venoactive drugs may have a role here on the inflammatory issues causing telangiectasia. So pay attention on that. And new studies with new devices show us that the circulation of the skin is much more complex than we thought. So sometimes, like in matting or some complications, we're looking for the cause and looking for the source. Where is coming this new telangiectasias, and sometimes it's coming from the sides. We do have a lot of things to work on and a lot of treatments. And Dr. Santiago put talk about something about pain, but here in Brazil, I've been using nitrous oxide and hypnosis in my office, and I invite you to know better these techniques, because nowadays I really don't have much issues on pain, even when I'm performing transcutaneous laser, which is the painful technique that we can use. Regarding lasers, I cannot agree that the 1064 is the best wavelength. I'm pretty sure it's the more versatile, but not the best, because the best depends on what kind of lesion, what kind of telangiectasia are you treating. So physics is mandatory to perform transcutaneous laser better, and also the outputs, like we can shoot a laser with a long pulse or nanoseconds, and it makes a very different behavior on tissue. So paying attention to that is important for you to understand which kind of laser to use in each lesion. So it's not very hard, although it's not on the educational program of most of the phlebologists in the world. So maybe we should paying a little bit more attention on physics basics, and even on engineering, because perfect laser, of course, it doesn't exist, but the way this laser delivers the energy is important. It can be in a free discharge that we call, or in more homogeneous, and it makes a difference on the temperature that we get on the skin, and also the beam shape. The beam shape is important, because it makes a difference on the reaction. Okay. Last thing, sclerotherapy. Of course, we do not have the perfect solution, but sometimes mixing it's better than using one. This is a brand new paper. It's in press yet, and showing that the combination is better than one alone. And sometimes we should look for histology, like Dr. Bush did it, and found a virtual perfect concentration of polydocanol for telangiectasias. That would be 0.3. So that way we can put the right tools in the right hands and using the right way. Okay. We need to use the intelligence to make things better, to make treatment better, and why not to make the world better. So be safe. Thank you very much.
Thank you so much, Professor Kikuchi. Outstanding taking on message contribution. Now it's my pleasure to pass the mic to a dear friend and also great dermatologist from the American Veins and Lymphatic Society, Margaret Mann. Margaret?
Thank you so much, Sergio. This has been fantastic. And I just want to thank everyone, especially the speakers, amazing lectures. And also, Sergio, this has been quite an endeavor for many weeks. So thank you for organizing this. It's been amazing for all of us. In regards to the talks today, I have three main points. So my first one is to really set realistic expectations with our patients when we start sclerotherapy and laser treatment. Remember, this is an aesthetic treatment. So at the end of the day, our patients are finicky. Their level of tolerance for side effects are very low. And I love this paper that Dr. Fabrizio and Willie published, I think maybe in the last year or two, about photos and how important photos are. So many of our patients forget what their veins look like after treatment, that many times I tell patients, I will guarantee them after sclerotherapy, their vision will be better, because they will look much more closely at their veins than they ever did before. And so frequently they'll come back in and say, well, what about this one? What about that one? I don't remember that being there. And I go, well, let's look at the photos. And so many times they are already there from prior. So definitely make sure you set realistic expectations about pigmentation, about what can be, you know, that sometimes it can take 3 to 6 months. And also make sure patients know what was there before, so they're not things that you caused. In regards to laser versus sclerotherapy, it's always this, which one should I use? And I think all of us agree that sclerotherapy at the end of the day is really still the gold standard. It is much cheaper. You can treat such a wide variety of vessels, from telangiectasias to reticular veins, that with laser systems, you really have to purchase more than one. And when it comes to cost, there's no doubt sclerotherapy is, in my opinion, the better, more versatile choice to begin with. Do understand, and I think the speakers gave amazing talks about minimal effective concentration. Be thorough and comprehensive in how you treat a cluster of vein, rather than just haphazardly treating here and there, because you're going to get better results. And I absolutely agree with Marlon that at the end of the day, while it seems deceptively simple, there are important techniques that even now, as I've done it for many years, I find that I've adopted and have improved my sclerotherapy results. And then finally, in terms of laser, they are very expensive. So even though I, in my office, have many lasers, I'm a dermatologist by training as well, but it is an investment. And so as Fabrizio mentioned, it has to be a worthwhile partaking for your office. So you can't just use it to treat veins on the legs, because you could easily do that with sclerotherapy. In my office, I often find that facial veins are one area that I do love using lasers for. I know it is controversial, but I don't like doing sclerotherapy on the face. I do think it's much safer to do laser treatments in that area. And then also, I call it my final treatment. When patients have scattered leftover vessels, this is one area where using a laser is very appropriate. But what's important is to understand endpoints. So at the end of the day, when you purchase a laser, the reps will tell you, oh, these are the settings you can use. But it is so important to understand the physics behind it. How do you, what is the endpoint you're looking for? How do you know you are actually where you need to be? How do you tailor the spot size, the fluence? How do you adjust all of that? Because that's really what makes somebody an expert versus a beginner. And then finally, a 1064 I do love, but you have to be super careful with this laser. Never double pulse. I always space my pulse, and I always wait a second before each pulse, because you can easily cause ulceration. Thank you.
Thank you so much, Margaret, for having demonstrated the honorary chair role is well put on you. So now we conclude with a big presence, Professor Kazuo Miyake, needs no introduction, Clark's technique father. So Kazuo, are you with us?
Hello.
Yes.
Hello, everybody. Can you hear me?
We can hear you, we cannot see you. Can you turn on? Yeah, now we can see you.
Yeah. Hello, everybody. Well, I will start with the last thing I wrote, because it's really important. Marlon Shu, I had the pleasure to play golf with him and Lisa Montangelo in Italy, in Rome. And he said something very important. How does the experience plays role to help to deliver the outcome, and how to guide the new phlebologist. And also, Dr. Margaret said at the end of her comments here now that the 1064 is really dangerous and you can burn the skin. Like, I really don't agree with this. Only if you follow the instructions of the dealers, of the one that sell the lasers, because they really want to show the effect right now, right there. To have safety and to have result, you need to use low energy and cook the vein slowly. And Margaret said that as well. Well, first, I will start with Fabrizio. I took some comments here. Congratulations for Fabrizio and Raul. Talks are really amazing talks. A lot of information right there. And he said about the laser physics. And one thing that I really, since the beginning, I didn't agree is the thermal relaxation time. This, and I put on the chat there a paper saying that is an outdated concept. And right in the beginning, in 1999, I started to use intense pulse light combined with dextrose in 1995. In 1999, the 1064, I started to use the 1064 long pulse with a 6mm spot size. And I've tested this laser comparing 18 milliseconds and 16 milliseconds and had no difference. And to change the settings between your session, you lose a lot of time, and class is time consuming. That's why I teach all my fellows and to use the same setting. The laser itself is really safe, and you just need to cook the vein. That means you use 50 joules per centimeter squared to 70 joules per centimeter squared, always 6mm spot size, the big spot size, and always 15 milliseconds, which is useful for all the situations. Bigger veins up to 1.5, sometimes 2 millimeters, and telangiectasia. The same setting for everyone. You will cook the vein because all the energy will go through the skin and will pass through the telangiectasias and the deeper veins. The big spot size is not focused at all at the bottom of the inverted cone of energy that it forms after crossing the skin barrier. Well, and I only use the monotherapy in the facial. And there is one thing that Fabrizio said, very interesting slide about the doors, and the yellow door is the leg veins. And you really can use the laser for a lot of all the skin, the head, neck, elbow, breast. After breast augmentation, sometimes I perform clacks on the breast. But the 95% of the situations in my clinic, I use 1064, and 99.9% I use the same setting. It means 6mm and 15 milliseconds. And that means the laser is really easy to use. And I've been teaching a lot of young phlebologists, and they start to perform right away. Raul Jindal, he said about the darker skin, and he has, of course, a lot of experience with the darker skin. This is really interesting. But the main point that I believe we need to take care is the classification. If we classify the patient and take out the patients that have reflux from deep venous system, they are, in my classification, the score 9-1, they are score 6 and above. That means they are telangiectasias or they have a feeder vein. They are not connected to a refluxing axial reflux. That means you will achieve a better result if you scan all the patient and get rid of all the bigger veins. And while you cook the vein using the laser, you just have to pass 2-3 times with the laser. Sometimes you don't see any effect at all right away, but as I've proved already with pathological examination after a phlebectomy in experimental study, the vein itself, it will have edema of the vein wall and destruction of the endothelium. That will lead to internal diameter reduction. And this will help you to inject very low dose of dextrose in the case of clats. I inject 0.01 ml.
It's me, Kazu, reminding you that the time is passing by.
Okay. And I inject 0.01 ml. Well, then the take-home message to summarize everything, it's diagnosis first. Photo documentation is really important as you are treating private practice. Use low energy, that will avoid you lead to less pain. And we are performing a lot of hybrid procedures where we, under sedation, the propofol, sedation and other products, anesthesiologist is there. We perform endovenous laser, ligation of the perforant veins, and also CLACS with 2 devices, 2 doctors. And in 3 hours, we really change the result. The patient's really, the outcome is really awesome. And the return of the investment, when you invest in a private practice, you buy a lot of devices, and the money itself is not so much. If you put this money in the bank, it will per month give you 1 session, 1 CLACS session. And if you decide to invest in aesthetic phlebology in a private practice setting, you will have to focus on that. You cannot like open a restaurant and sell a cheap hamburger and like a very fancy food. You need to focus on that market. That means you have the devices, you need to use those devices because the result is much better than the other techniques.
Kazuo, I need to stop you because if not, they will have no point in coming to IMAP and enjoying all the other teachings if you keep on saying everything now.
I just added.
So,
yeah.
So let me now turn toward the end of this webinar, deeply thanking everybody, starting from the first travel mates, so friends and colleagues and family to me, Professor Bottini and Professor Shi for the final remarks. Oscar.
Okay, thank you. Another Sunday with excellent presentations and a great brainstorming. We'll meet again next Sunday. Thank you all and see you then.
Thank you so much. Willie?
Yeah, I'll be sure when there. Good morning, good afternoon, good evening. See you next week.
Thank you so much for being so operative. Thank you so much to all the ones involved in this group effort. Thank you so much to our Michael Jordan and Andra Joig champs in our field, also for the time they will take to answer to the questions in written form during the week. We look forward for being together next Sunday on coagulation with truly giants of the field. Before saying goodbye, I'd like to have a last word from dear friends who are believing in teamwork and international teamwork indeed, and also in gender equality. So first I will give the mic to Marlin Schul and Margaret Mann for a nice initiative of the VLS, and then to Lorena Grillo for next Saturday initiative. Margaret or Marlin, would you like to say a word?
Just real quick, Sergio, a great example of how you can have an outstanding virtual meeting. Margaret is our chair of the meeting this year, and I can tell you the amount of effort, and we've had a lot of experience watching other events and optimizing what we're going to be able to provide in October. I'm going to introduce Margaret and have her give an overview of what our meeting is going to show in October. Thank you.
Yeah, I want to personally invite all of you guys to our meeting. So October 15th through the 18th, it's a 4-day conference. We have 4 simultaneous tracks, superficial, deep veins, lymphedema, ultrasound. It's going to cover both beginners and experts in the field. We have a total of 80 CME hours. Everything's going to be recorded, so you have the chance to go back and rewatch everything till the end of the year. All of it is going to be interactive, case presentations, question and answer, much of the stuff that Sergio has done. Fantastic. And Sergio, Marlon, Willie, lots of folks here are involved with the meeting. Last thing, prices have been reduced significantly from our in-person meeting. It's at least about $500 or $600 less than what we normally charge. And for everybody who is from a developing country, there's an additional 40% off. So I hope all of you guys will join us in October. Thanks so much.
Thank you so much. A quick leap toward South America with Lorena Grillo. Lorena, would you like to tell us about next Saturday?
Thank you. I want to invite all of the colleagues and related professionals to join us next Saturday, August 22nd, in this same schedule, and participate through Zoom, Facebook, or YouTube. And we'll have great faculty in this Women to the World in Phlebology that will include a worldwide group of dynamic women in the field. We thank Dr. Bottini and you, Dr. Giannesini, for allowing us to support this pre-Congress activity forward to the support in Latin America and also gender equality. Thank you very much.
Thank you so much all. Deeply thank to all the ones who joined us today in this group effort. Sorry if we went 5 minutes later, but we are like giants and we really didn't want to stop their teachings, and we look forward to be on together next Sunday. Thank you so much. Have a wonderful day. Ciao. Bye.
Oh, bye-bye.
Bye.
Bye.